Welcome to Preview Power Week. If you are joining us now, welcome. Today's day 5. I'm Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation, CPBF, and your host for this event. The Preview Power Week is the second of 2 international live series that CPBF is hosting in 2020 in recognition of World Prematurity Day. These educational sessions are in collaboration with the International Family Integrated Care Committee, the Canadian Association of Neonatal Nurses, EFCNI, and GLANS, the Global Alliance for the Newborn Care. For those not familiar with CPBF, we are a charitable organization, and our mission is to support and educate Canadian families of premature babies every step of the way. We believe that through consistent information, access to helpful resources, and peer support inside and outside the NICU, we can empower families, ensuring they are ready to care for their baby. Consistent information is especially important today when we are facing a global pandemic. With educational sessions like this, we intend to bring you the guidance of healthcare professionals and the knowledge gathered by researchers around the world. These are valuable tools to help our community raise awareness and advocate for the well-being of families and their babies. And I would like to thank AbbVie for the unrestricted educational grant and Pampers for supporting the Preview Power Week. And right now we're going to talk about hospitalist midwives improving Indigenous cultural safety in neonatal intensive care units. This presentation will provide an overview of the role of hospitalist midwives in addressing cultural safety for Indigenous families in neonatal intensive care units of an urban level 3 hospital. Taking a strength-based approach, we will outline the disparities in health outcome in Canada, explore the importance of culture and ceremony in birth and the early postpartum, and provide examples of initiatives taken to improve care for Indigenous families. Joining me here from Toronto, I have Claire Osepchuk, who is a registered midwife at 7th Generation Midwives in Toronto, and a hospitalist midwife at Sunnybrook Health Science Center. She's a descendant of settlers from the UK and Ukrainian immigrants. She has an academic background in biochemistry, medical health research, and teaching. Claire is committed to supporting her Indigenous and non-Indigenous colleagues, clients, and their families. Also joining us is Claire Dion Fletcher, who is also a midwife, a Potawatomi Lenape, and mixed settler registered midwife practice in Toronto, Ontario. Claire is co-chair of the National Aboriginal Council of Midwives and an assistant professor in the midwifery education program at Ryerson University. Claire is dedicated to the growth of Indigenous midwifery in Canada and the expansion of Indigenous midwifery education. Welcome both, Claire. I'm so honored to have you here today to talk about this very, very important topic. We just talked with Dr. Paula Duran. I know you're watching us about disparities in care, and I'm looking forward to continue this piece of education. How can we educate our healthcare providers on different cultural aspects and how include everyone into the picture? So thank you both.
Great, thank you for having us. So I'm gonna jump right in because I was gonna introduce myself, but I think you covered everything in that intro. Thanks, Fabiana.
Okay, so I will start with the objectives. So the objectives of this presentation is to describe the role of the hospitalist midwives in addressing the cultural safety for Indigenous families in the NICU. And we currently work at a level 3 hospital in downtown Toronto. We're going to review the importance of culture and ceremony in birth and parenting. And we are going to describe the initiatives taken to improve perinatal care for Indigenous families.
So we just wanted to start with a brief description of what we do as registered midwives and a little bit of information. I know some people will be aware of what midwives do in Canada, but just wanted to make sure we all have a good understanding of our role. So in Ontario, midwives are primary healthcare providers during pregnancy, labor, and birth, and for 6 weeks postpartum for both the postpartum person and for the infant. There's three main tenets of midwifery care in Ontario. We believe strongly in continuity of care. So generally that means that our clients meet a small number of midwives, usually about 2 to 4, and one of those midwives is always available for them. We do prenatal care, the same midwives attend the birth, and the same midwives do postpartum care. We also believe strongly in informed choice. We really believe that the best way to access care is for our clients to be in control of their healthcare and in control of what happens to themselves and their bodies. And so informed and choice is really important for us. We facilitate, a lot of people being involved in clients' care, but ultimately the decisions of what happens is up to the client, and we help make recommendations and help them make those choices throughout their healthcare. As midwives in Ontario, we also believe strongly in choice of birthplace. So when you have a midwife, you can have a home birth, you can have a hospital birth, or if you are in a city where there is a birth center, you can also have your baby at a birth center. So those stats there are the percentages of midwifery births that occur in those three locations across the province. So I'm going to speak what will seem very briefly because of our time about the role of colonization in health inequities in this country. I wanted to start by saying we're going to be touching on a number of serious issues that affect Indigenous people. It's really important that we acknowledge these issues of pain and violence in the lives of Indigenous people in this country. However, it's also equally important to remember that this is not all Indigenous people are. We also have a lot of joy and love in our lives from our families and our communities, and especially from the resurgence of our culture, our teachings, our knowledge, and our ways of being, which we're also going to speak to as well. So while it's important to acknowledge the racism and health inequities that stem from it, I would also really encourage everybody to understand that this is not all Indigenous people are, and that there is, as I said, lots of love and joy in our life and in our families. And that's really important to remember when providing care to Indigenous people. I think it is crucial as healthcare providers and as advocates and just as everyday Canadians that we have an understanding of the history of and the ongoing process of colonization and how this affects the health and well-being of Indigenous people. So some of the things we're going to talk about are the kind of main things that we see as impacting Indigenous people's different experience in healthcare, and really what makes oftentimes healthcare inaccessible to our Indigenous clients. So these include experiences of racism and discrimination, colonial policies and their institutional interpretations, and poverty and the social determinants of health. So I'm going to just touch really briefly on some of these Canadian colonial policies that impact Indigenous people's health in Canada. So some people may have heard of the Indian Act. It is an act of government that came about in 1876. It is a large act that incorporates many aspects of Indigenous people's lives. So very quickly, some of the things that the Indian Act has enacted upon Indigenous people is a dispossession of land and a disruption in traditional economies, which has a continued legacy today in persisting poverty. It disempowered Indigenous people's identities, especially those of women and children. The government defined who could be considered Indian by the government. It undermined traditional societal structures, which were often matriarchal and or matrilineal. It also resulted in the reserve system, which separated people from their lands. It separated families, and it specifically isolated women and children from their communities. It also resulted in forced relocations. In this country, we have a history of medical experimentation on Indigenous people. Since the Truth and Reconciliation report on residential schools, many stories have surfaced about the inadequate treatment of Indigenous children in residential schools who were used as test subjects for treatments to TB, and reports of unexplained surgeries on patients in hospitals. The legacy of experimentation on Indigenous people, including children, and the intergenerational impacts can still be felt today. We have the legacy of residential schools, the last of which closed in 1996. The sexual, emotional, physical, mental, spiritual, and cultural abuse that was experienced by generations of Indigenous children who survived residential school has resulted in profound impacts on the physical, emotional, spiritual, and mental health of the survivors, their families, and our communities to this day. It is also important to remember the many, many children who never returned home from residential school. I also wanted to talk about the historic and current child welfare practices that occur in this country. So some people may have heard of something called the 60s scoop, and more recently something that we refer to as the millennial scoop. So the 60s scoop is a period in time in Canada, in Canadian history, in the 60s, as you can imagine, where in one decade, approximately 1 in 3 Indigenous children was apprehended from their families and communities. Children were adopted, usually by non-Indigenous families, by families outside of the country, and often without any records of where the children went or where the children came from. By 1970, Indigenous children accounted for 30 to 40% of children in care, when Indigenous people accounted for less than 4% of the national population. Now, some people may be very surprised by this and think this is a very staggering statistic, which it is, but this is something that did not stop in the 60s. Currently, about 48% of children in care in Canada are Indigenous, while 4.3% of the Canadian population is Indigenous. This is crucial when we're talking about people accessing healthcare, especially new parents whose babies are in the NICU and in hospitals. It's important that we think about this when we're talking about the right to parent our children in safe environments. In many Indigenous communities, there's a lack of access to basic human rights, such as clean water and adequate housing. In this country, there's an over-surveillance of Indigenous people by the justice system, which results in disproportionate amounts of Indigenous men and women in jail and the health effects that goes along with this. We are also experiencing an epidemic of violence against Indigenous women. Indigenous women experience higher rates of spousal and non-spousal violence. We are 8 times more likely than non-Indigenous women to be murdered, and we are just as likely to be murdered by a stranger or an acquaintance as we are by an intimate partner. And the last thing I want to touch on is structural racism. So institutions, including healthcare settings, are designed in such a way that does not take into account the experience of Indigenous people, and as such, creates barriers that non-Indigenous people may not even recognize. So we started with this discussion about Canadian colonial policies and their current legacy today because we think this is extremely important history and current practices that really affect Indigenous people's ability to access healthcare and to feel safe in the healthcare system, where I think we can all agree that people should feel safe and cared for in our healthcare system. That is not the case. So one thing that we're asking you to do today is to think about your assumptions about Indigenous people and how this history of assimilation and attempted genocide in this country has affected your own opinions and picture of who Indigenous people are, what we look like, how we access care, and how we parent our children. So the medical community is starting to recognize the various ways that the colonial legacy in Canada contributes to the overall ill health of Aboriginal people compared to non-Aboriginal people. I'm going to just list a few ways we see this, and then Claire is going to go into these things in a little bit more detail, more related to our topic today. So we see increased rates of chronic disease in Indigenous communities, increased rates of dis and differing ability, increased rates of addiction and substance use, increased rates of suicide, and increased rates of infant mortality.
Thanks, Claire. So the next 3 slides show data from a community-driven health survey for Indigenous people led by Indigenous people. Specifically, it was led by 2 of our colleagues at 7th Generation Midwives Toronto and Well Living House. Well Living House is a research center focused on Indigenous health and well-being, led by a group of Indigenous health researchers, health practitioners, and community of grandparents. As Claire mentioned, we know that the impacts of colonization and colonial policies, such as the Indian Act, residential schools, the 60s Scoop, and continued exclusion of Indigenous people from the Canadian economy are reflected in the higher rates of unemployment and lower socioeconomic status. Research has shown that Indigenous people are undercounted by the national census, and that Statistics Canada has significantly underestimated the prevalence of poverty among the urban Indigenous population in Ontario. So this is what led the Our Health Counts health survey. The Our Health Counts in Toronto study found findings that indicate that there were 45,000 to 60,000 Indigenous adults in Toronto. This is 3 to 4 times more than the estimated number by Statistics Canada. So the data from the next 3 slides is from this larger population of Indigenous people in Toronto. The point I want to highlight from this slide is that Indigenous people who participated in this research study reported they wanted to access prenatal care, but 26% of them did not access care at all, or they only accessed it in the 3rd trimester. In comparison to 95% of women in Canada who had their first prenatal visit before 13 weeks. The survey found that people who had experienced discrimination from a healthcare professional were 2.5 times more likely to not access prenatal care at all, or again, only in the 3rd trimester. One of the major barriers to accessing care was reported as a lack of trust in a healthcare provider. Due to care access issues and systemic discrimination, Indigenous parents experience stress, a lack of social support, poverty, and medical conditions, all of which increase the likelihood of having a premature birth. This survey showed that 1 in 5 Indigenous infants in Toronto were born prematurely or before 37 weeks gestation, compared to 8% of the infants in Toronto. This is almost 3 times higher for these Indigenous infants. And Indigenous infants born in Toronto were 2 times more likely to be both small for gestational age and large for gestational age. And a smaller number of Indigenous infants were born in the normal weight category than other infants born in Ontario. As you know, neonatal intensive care units, or NICUs, are equipped to provide specialized care to premature babies and babies born with medical issues. The main reasons babies are admitted to the NICU are low birth weight, prematurity, and respiratory conditions. This slide shows that 1 in 5, or 21% of Indigenous infants in Toronto were admitted to the NICU after birth, compared to 13% of all live births in Ontario. As well, they had a longer stay in the NICU. This is partly due to medical indications, but also because of the stigma around Indigenous people and their parenting abilities, which delayed the discharge of their infants to their homes.
So we know that in Canada, there's an increasing body of evidence that Indigenous people do experience differential treatment and health outcomes than the non-Indigenous population. We need only look at recent news stories to see the way that this manifests in our healthcare system. The important thing to remember that while news stories such as the recent death of Joyce Echaquan or the story of Lisi Kloski, the Inuit elder who had to call 911 while she was in the hospital because she was refused water, or the viral video a few summers ago of the apprehension of a baby in BC, often appear as sensational news stories. These are everyday occurrences in the lives of Indigenous people. This isn't happening in other places. This is happening all across Canada in our communities. So we wanted, with that history and a little bit of background about the Indigenous population, we wanted to shift a little bit into talking about some of the things that we do as midwives. So right now in this country, we are actually in a real moment of resurgence of Indigenous midwifery and Indigenous knowledge and practices surrounding birth. And we wanted to talk about that a little bit. I have here on this slide 3 quotes from Indigenous scholars or elders, or both, about the importance of birth pregnancy, birth, and early postpartum in Indigenous communities and to Indigenous families. One of the things that we think is really important to highlight is that as a community and a group of people that has experienced forced assimilation and an attempted genocide, agency of our reproductive choices and lives and ability to parent is obviously extremely crucial. This is particularly important for Indigenous families. So traditionally, Indigenous midwives had very crucial roles in our communities, and Indigenous women's reproduction and families and our control of our families was an explicit site of colonial violence that was meant to disrupt the power of Indigenous women and to disrupt Indigenous worldviews. So this is why knowledge surrounding pregnancy and birth and early parenting is particularly crucial. We know that pregnancy and birth is a time when many clients are deepening their connection to their culture and to their identity, when they seek out teachings and knowledge and ceremonies that ground them in their culture, that can create an environment for their children that celebrates their culture. So that from the moment of birth, which is something that Gaji Cook often talks to us about as Indigenous midwives, babies are born into their culture and feel a connection to this culture and a strong, healthy identity. Building a strong and healthy Indigenous identity can and does begin in pregnancy when women are seeking out care that is culturally safe and grounded in Indigenous knowledge and ceremony. They are surrounding their baby in a positive and strong cultural environment where their families, where our knowledge systems, where our worldviews, and where our practices are respected and celebrated rather than looked down upon and as a site of violence.
So how do we improve perinatal care for Indigenous families? Well, what we did is we asked them. So we asked them specifically their barriers to accessing healthcare, what supports they needed, and what they wanted. And here were some of the responses. So the families that responded specifically said they wanted family supports. They wanted their family members to be an integral part of the decision-making in their perinatal care around pregnancy, birth, and for their babies. They wanted to be linked with Indigenous parent groups. They wanted to be with other Indigenous parents and talk about their situations. They wanted Indigenous healthcare providers and culturally safe healthcare providers who could not only locate themselves in the healthcare system and in the world, but also someone that they could talk to about anything and not just about pregnancy and birth. They want more breastfeeding and lactation support. And they want to be supported to make their own decisions around their care, which can include choosing their own healthcare provider. They want safe spaces in hospitals to be able to practice cultural traditions and ceremonies. And they want a continuity of care provider throughout their care. Other important things they said that they needed were outreach and cross-agency referrals, services that were closer to home and to transportation, access to funds for urgent material needs, help with childcare, and even stable housing and food security. So you can see how they're not directly asking about care always for themselves and their pregnancy, but actually being supported in every aspect of their life will drastically improve their perinatal experience and their health outcomes for themselves and their babies. So we're Seventh Generation Midwives Toronto is the practice where Claire and I work. It was established in 2005 with 3 midwives with admitting privileges at Women's College Hospital in downtown Toronto. SGMT's mandate is to work with and support the urban Indigenous community in Toronto. We believe and are committed to providing midwifery care and Indigenous midwifery care that enables families to reclaim control of birth for themselves. Currently, we are 18 midwives, 9 of whom are Indigenous, plus 2 Indigenous family physicians, and several ongoing special projects that support the Indigenous communities. Hospitalist midwives. So this is a new program running out of SGMT. It started in September 2018. So it's a partnership with Seventh Generation Midwives and Sunnybrook's Women and Babies program. There are 4 of us in this specific program. We call it the Indigenous Midwifery Program, and several of these are funded by the Ministry of Health and Long-Term Care, scattered throughout Ontario. We have 2 hospitalist midwives who primarily work in the hospital. One of us is there more Monday through Friday, daytime hours, and the other one takes a bit more on-call work for urgent situations. And we also have 2 midwives who work in the community. And often we share care with clients, so to be able to provide clients with support in the hospital setting and then in the community as well. So for us as hospitalist midwives, we work throughout the Women and Babies program, but you'll find us primarily in the high-risk clinic. So this is where pregnant patients come when they need to see specialists. So either the MFMs or the maternal fetal medicine or specialist OBs. They might need ultrasounds at every appointment. They might also need to see dietitians, advanced practice nurses, hematologists. And we created an ability for a midwife to also be part of this interdisciplinary team at their prenatal care visits. We also work on the birthing unit, providing labor and birth care. And we provide support for clients who use the high-risk obstetrics day unit or are admitted there for complications in their pregnancy, sometimes for a very long time. And we also support families who have babies that have been admitted to NICUs, who again could be there for short amount of time or a very long time. So some of the highlights of our role would be expanding midwifery services in this interdisciplinary team model care. So I previously mentioned if someone's coming in to see a specialist, they don't have to necessarily lose their midwives. So a lot of the people that we see are actually midwifery clients that wanted midwifery care for their pregnancy, birth, and babies, but perhaps due to a medical history or a current medical condition, or maybe a complication in the pregnancy that developed, they need to access a specialist care. So we're able to still provide them with that midwifery care. Again, we have more time to sit with them a little longer, answer their questions, and potentially fill gaps in where they might need care in the community. Another one of our important roles is to increase cultural safe care, particularly for our Indigenous families. So that might mean for me as a settler to facilitate families to practice a cultural ceremony, or it might mean having an Indigenous midwife come in to support them in whatever way. We accept referrals for any patients who access the Women and Babies program at Sunnybrook who are not currently under midwifery care, at least with SGMT, if they could benefit from additional midwifery support, and in particular, Indigenous midwifery. So some referrals come from people who are transferred from out of region for a complication in their pregnancy, and they need to be admitted to hospital for a while. So they've been separated from their families and their communities. Or if they are midwifery clients from another practice, again, being transferred to Sunnybrook for some complication in pregnancy. We can provide additional support for families with social complexities and for families that have child protective services involvement needing extra parenting support. So some of the activities of the midwife hospitalist are, again, providing clinical care for pregnant people that is holistic, culturally safe, and respects Indigenous beliefs and values. We provide health literacy and knowledge translation. We're fortunate, again, to have a bit more time to sit with our clients, review their blood work, look at their ultrasounds, answer any questions they might have about their care plan from the specialists, try to figure out what they need and how to support them in other aspects of their health. So maybe even things in the community or supports they might need at home. We support our clients to navigate the healthcare system. If there are complications such that you need to see a couple of different healthcare providers, sometimes it can be overwhelming. So we help facilitate that. We support engagement with different healthcare providers, as well as community supports. We provide mental health support and facilitate access to resources. So that could be within lots of the different resources at Sunnybrook, or maybe if clients are wanting support from the Indigenous community, we can help link them up with supports there. We work to advocate to strengthen families and keeping families together. So one example is we can provide that 6 weeks postpartum care for clients who maybe weren't even midwifery clients to begin with, like they only had an OB, to provide extra parenting support for those first 6 weeks of their baby's life. And we facilitate and honor traditional roles, ceremony, rites, and protocols surrounding birth and families. So we have relationships with elders and knowledge keepers in the community. So we can offer, if clients are wanting to speak to someone, to facilitate that visitation. Right now, of course, things have moved virtual, but when restrictions are lessened or visitation is allowed again, we can actually bring elders or knowledge keepers to the hospital for people who may not be able to leave because of their condition. We provide medicines for cultural practices. We find those safe places for people to practice those ceremonies. Sometimes it's in an education room, sometimes it's in the garden outside the hospital, but we help our clients find those spaces to do that. I already mentioned providing postpartum care in the community for some people who need extra support, and providing them with access to community services, and just having time to sit down and figure out what they need. So why are they missing a prenatal appointment? Is it because they don't have childcare? Are there challenges for transportation, so that they can really access the care that they want to access? So what can you do? What are your calls to action? So I think number one, if you haven't already, you need to read the Truth and Reconciliation Report. You need to make a commitment to look at the impacts that your work has on Canada's Indigenous people, and including both the intended and the unintended impacts of your work. You need to build relationships with the communities in and around where you work, and directly ask your community what they want and how they need to be supported. One of the calls to action specifically states, support innovative and culturally safe models of care dedicated to serving Indigenous infants and families to begin closing those gaps in the healthcare between Indigenous and non-Indigenous Canadians. Another call to action is for all healthcare providers to take Indigenous cultural safety training. There's an excellent one that is funded by the LHIN in Ontario. There's another excellent one offered in BC and in other provinces and territories. There are many modules and opportunities to take this type of training. These trainings offer a deeper understanding of how to identify systemic racism in healthcare, how you can reflect on your role in this racism in healthcare and try to change it. Another call to action would be to find different ways to support or get involved with different Indigenous and or midwifery initiatives happening through the perinatal programs. So for example, support the implementation and scale up of culturally safe family-centered care models in the NICUs, address barriers for Indigenous parents and families in being with or providing care to their babies who are hospitalized in NICUs, which include helping solve barriers, financial barriers for accommodation, transportation, and food security in childcare. Create dedicated spaces in hospitals and clinics for traditional cultural practices and ceremonies. And link Indigenous families with infants admitted in hospital NICUs with Indigenous perinatal workers and or midwives for ongoing cultural support. Thank you very much.
Sorry, I just realized I was mute. So I want to thank you, both of you, for this great presentation. And Claire Dion Fletcher, thank you for the history lesson. I think this is so very important for us to remember the history, learn about the history. As an immigrant, I didn't know about this piece of history. And I started learning when my son was in grade 3, that came home, talk about residential school. And I asked my husband, who was born and raised in Canada, also son of an immigrant, what is residential school? I never heard of this. He said, me neither. So I think there's a lot of teaching and learning that we have to do as a society. And I'm so grateful that you brought this piece to this presentation, because I think it's crucial for us to understand, first of all, to understand, acknowledge, and then how we will move forward with less racism or no racism at all, because I think that's the goal, to eradicate racism altogether. So I have a question here from a private chat. Canada has a long-lasting experience work with Indigenous population. How is the response from the Indigenous groups regarding prenatal and newborn care? Are traditional midwives involved, and do they work on working together with them? What are the main challenges?
Fabiana, could you just read the beginning of the question again for me?
Canada has a long-lasting experience working with Indigenous population. How is the response from the Indigenous groups regarding prenatal and newborn care?
Claire, do you have any?
Well, I would actually argue that we actually need to improve the healthcare that we provide for Indigenous families, and that, as Claire mentioned, in our history in Canada has been that we've drastically disrespected and have not provided good healthcare to Indigenous people. So I think, as we mentioned, it would be important to actually ask a community, if you're trying to sort of improve the care for a community, what you need to do is to ask them what they want. So there's a quote that's I think relevant, is about nothing for us without us. Again, not Indigenous, but it's really important to basically ask what you need. So that's what we did. Our colleagues and all the excellent workers with the research center actually went out and did that work of asking that 45,000 to 60,000 Indigenous families in Toronto, lots of different aspects of their healthcare actually, so not just prenatal care, to really say, like, what are their barriers? And so I think we have a lot of information of where we can improve things to increase better health outcomes for Indigenous people in Canada.
Yeah, I think, sorry, if I can just say one thing. I also think that that's one of the reasons why we see, like, we see Indigenous midwifery look so different across the country. So, like the midwives who are working in Northern Quebec and Nunavik, the midwives who are working at Six Nations, us at SGMT in Toronto, midwives who are working in the Northwest Territories, who are working in BC. Our midwifery programs look so different because for us, we really start with our communities and ask and try to find out what our communities need and then go from there. And I think that's a really crucial thing that is really how we're going to be able to address care and better meet the needs of our communities is by talking to our communities and seeing what they need. We can't decide for them what it is that they need or what we think they need.
So we have a comment here from Dr. Duran, from the World Health Organization, who just spoke to us before, said it would be great learning and sharing the experience with other groups who work with Indigenous people in other countries. Absolutely. We have a lot of work to do for sure. And I think we can all learn this together. So Claire, my question to you is, well, both Claire Dion Fletcher, now like, okay, a little confused with the Claires, but my question is, big centers, obviously where you are, is highly supportive of your work, and you bringing your cultural traditions into these big hospital units. Are all hospitals open to receive you as a traditional midwife in the units to work with families?
Yeah, I think it really varies. And sorry, there's a bit of feedback there. I think, we've had our experience at our hospital and different, I don't think it has to do with the size of the hospital. I think it depends on like who's in leadership and what the goal of the hospital is, and what like the knowledge of the experience of Indigenous people in healthcare is of the people in the hospital. I've seen from my Indigenous midwifery colleagues them be very well received in the hospital. We get lots of support from doctors and from nurses and from administrative teams. And then there's other hospitals and places in the country where we just don't get that support at all.
So do the chain have to start with leadership and then go down the chain, or vice versa? How do we put the pressure from the ground to the top, or is it all the way around?
Personally, I think it's a little bit of both, right? I think it's, for big changes to happen, there has to be support in leadership and support from the top. But as like individual care providers, we can do a lot to change how people experience that individual moment, and can really affect people's experience of healthcare. And I think like affect whether they will access healthcare again, right? So one of the things Claire had talked about was like when people have an experience of racism or discrimination in the healthcare setting, or you hear about it from a family member, then that actually prevents people from accessing healthcare later. And that's really important in having good health outcomes.
Okay, so let's talk about the NICU, because I learned a few years ago the role of the grandmother for Indigenous population, and the grandmother is the one who helped to raise the child. So when you look about in the NICU, when you consider the parents to be the mother and the father, or the two mothers, whatever the family unit is, we never include the grandparents. How is that for your culture? How is that in the NICUs from your experience that is happening in the country?
It's so hard, I think, right now with COVID to think about like how our experiences are, just because they've been so affected. And I think that's something that, we obviously want our families to be around us, and our family is very important. And I think it's also important to remember that in Canada, we talk about like Indigenous people and First Nations and Inuit and Métis often as a group, but it's really important to remember the diversity within the Indigenous population, and how our communities have lots of different traditions and knowledge and practices. But I think especially during COVID, one of the important things to think about that as Indigenous people, we are also thinking about is protecting our elders, and that, yes, we all want our family to be there and be with us, but we also know that protecting our community that already has an increased burden of disease is hard. And sometimes that means not having the people with us who we want in order to protect them from disease. Because in many communities, if COVID comes to our communities, there is very little access to healthcare, and that's something that we need to take really seriously and think closely about, and that we are. I kind of went off on a tangent from your question, but
no, but you answered the question. But my next question is, when you talk about the midwives in the hospital, you support the mom 6 weeks post birth. So how does that happen in the ICU? Do you take especially this time when the families are isolated, there is no extended family, do you take a little bit of their role?
Claire, I'm leaving that one for you.
I have noticed that in the pandemic, especially when the restrictions were so tight and a lot of pregnant people were, say, on the unit, they couldn't leave because of complications, were anticipating a preterm birth. So lots of anxiety for those people, and they couldn't have a single visitor. And, I'm not sure if I had grandparents alive today, they would be able to virtually visit me or have access to internet or smartphones. My mother has challenges with that. So what we noticed was we had perhaps a lower number of referrals for families during the pandemic, but actually we spent so much more time supporting to them, listening to them, trying to facilitate things. Claire and I were doing FaceTime with the baby in an incubator to a mom up on a really northern reserve every day through Christmas, actually. So this was before the pandemic, but we do a lot of things like that to try to connect people with their families. And we ask everyone to fill out a patient survey, and a bunch of our surveys have said that we helped at least sort of fill a bit of a void of a support person. Of course, we're not a replacement for their family member, but at least to have someone that's visiting them. Even though we also wear the healthcare provider hat, sometimes we just sit and listen to what's going on and what's really stressful. It's not always about reviewing that ultrasound or the next test their baby has to have.
Right. So you mentioned a little bit in your presentation about how we can improve the family support when they are in the ICU. I would like to review that piece because I think that is so important, that message. How can we improve that? Not only in your unit, but in units across Canada.
Well, I think actually our unit does a great job. So forget the pandemic, but prior, family members could visit. The parents just had to sort of bring them in. So we were bringing grandparents in, aunties, uncles. We were supporting cultural practices, finding places for ceremony. So I think we had a great policy, and the NICU in Sunnybrook works really hard, and they recognize how family support is so important. Perhaps not necessarily from an Indigenous perspective, but in general, that support is really, really necessary for families. So I would say if there are more strict visitor policies, again, trying to not include COVID restrictions, is to really recognize that the restriction on visitors is hard. So even that brings me to thinking on the birthing unit. Typical hospital restrictions are you bring 1 or 2 support people. Some of our clients want to bring their whole family, and it's just not allowed in the hospital. So having the option of an out-of-hospital birth, again, so we're not talking about babies that are being born prematurely, but at the birth center, we can accommodate an entire family and any ceremony that they want to do, and that's really important. So even though I think our NICU is great, I'm sure others can improve, and I think our birthing unit policies could improve to really recognize the importance of family in the pregnancy, birth, and postpartum and infant life.
So Claire Dion Fletcher, can you tell us a little bit about the ceremonies when the baby is born? Teach us a little bit about the ceremony and how we were keeping those ceremonies alive today in times of COVID.
Yeah, I think it's a bit of a difficult question to answer because everybody's going to have different things. So I think one of the points that you made about the understanding the importance of extended family and understanding the roles that different family members may have might be different in Indigenous families than in non-Indigenous families, or might just be like different than what you're used to seeing. And I think I can't really speak to specific ceremonies just because there's so much diversity. But really being, I think, open to that and to listening to clients about what they need and asking and like practicing and learning how to do that in a respectful way, right? Is that it's difficult. It's something that we're not always used to doing. And so being able to really talk to any clients or any patients about what it is that they would like, and then figuring out the systems, because sometimes the hospital system isn't set up for those things. And rather than kind of saying, no, that's not going to work, thinking about like, okay, so what can we do to make it work? And what kind of things can we change to make this available?
Absolutely. Yeah, so moving forward after the NICU discharge and families are home, now we want to have all the voice at the table. We want to have everyone involved in research, in discussions. How can you move forward and improve experience of Indigenous families in the hospitals? So how do we engage Indigenous people in that piece of the system? Because I feel I sit in a lot of different committees for research, for advisory committees, and I feel there is always this lack of representation. So how can we bring that to the table?
Well, I think it's actually get Indigenous people to those tables. So a lot of hospitals on different committees will want a parent representative, for example. So it would be, if you're trying to provide care in a specific way, again, for any community, you want to bring Indigenous people into it. So I think we need to have more Indigenous healthcare providers. We need to have more Indigenous perinatal support workers. We need to invite people, but again, in a respectful way. So, because we're actually asking them for their time and their experiences. So, it's not about bringing someone in and paying them to talk, but actually like thinking about, well, what is sort of the Indigenous framework around this type of help? So maybe it looks quite different. Maybe it's sharing a meal. Maybe it's getting families together. I don't know, but I think it really, really has to start with asking Indigenous people what they need and asking them if there's challenges to get people there. Well, why? So then, what are you asking them? Why is it not happening? And somewhere you might get lucky to have someone who has the time and resources and energy to say, this is how we can do it better.
Absolutely. Claire, any final thoughts? Claire Dion Fletcher.
I think that was a great answer from my colleague Claire. I think also just remember that, the experiences that I talked about in terms of our clients are also like my experiences, right? And our experiences as healthcare providers. And so, though we may have be working in a system and seem to be doing well and flourishing in that system, it's not really our system, and it's not necessarily where we want to be putting our energy. When taking care of our clients is often takes a lot of our time and energy and where our focus is, and just keeping that in mind and thinking about, kind of as Claire said, like what kind of different systems need to be made and how could we alter what we're doing to be more inclusive. Yeah.
Okay, so I would thank thank you both of you for joining us here today. Such a great conversation. I'm sure we have much more to talk about and many more questions, but I'm so grateful for what you share with us today. And I hope a lot of people are taking notes on these lessons from both of you and how can we be more inclusive. Thank you both.
Thanks for having us.
Thanks, Fabiana.
Thank you.